But yeah, really, really pleased. This is our, final presenter for the lab day, and really, really excited that this is also being co-hosted with the department. So thank you, Scott and Jen, for making this possible. We're really delighted to have Davide Papola here, who will be talking about his work. Just I'll briefly introduce Davide. I don't want to take too long because I know he has a flight to catch. But he is a psychiatrist, and he also has a PhD in psychiatric sciences. He's based at the University of Verona in Italy, and works with in the research group of Professor Corrado Barbui, who many of you know in mental health services work, leads many of the large-scale projects with the WHO. So it's really an outstanding research group that Davide is joining us from. We've been really fortunate to have Davide as a member of our team for over the last year on a Marie Curie Fellowship from the European Union. So he's been working on a project called Reshift, and Professor Vikram Patel has been his primary mentor on this work. So we've been really delighted to have Davide here, and he's going to talk to us a little bit about the Reshift project. And I'll turn it over to you, Davide. So thank you.
Thank you, John. Good afternoon to everyone. My name is Davide Papola. I'm an Italian psychiatrist, and this is the final lecture of the outgoing phase of my Marie Curie postdoctoral fellowship here at the Mental Health Lab, Department of Global Health and Social Medicine. My EU-funded project addresses one of the leading causes of disability worldwide, ever-increasing prevalence of depression and anxiety. We know that psychological and social interventions are effective for the treatment of these disorders. In poor resource settings, though, for feasibility reasons, these interventions are not delivered by mental health specialists, but by trained lay health counselors, so that a wider audience can be reached at lower costs. However, these interventions are compilations of multiple distinct, possibly interacting active treatment components, and it is not yet known which of these components or combination thereof are the most effective. So how to disentangle the efficacy of components and understand which of these works best and for whom? Well, this is the research question I'm trying to address. And to do that, I'm implementing a sophisticated research design that will allow me to identify the impact of participant-level prognostic factors and effect modifiers on intervention outcomes. Once the results of my project will be automated into software, it will be possible to tailor interventions according to the needs and preferences of people living with depression and anxiety. But above all, this is the story of a mixed method study. It's of its strengths, its limitations, and my obsession for getting the qualitative and the quantitative part of the project to converge, so at some point they can there is a connection between the two methods, just like two miners digging toward each other, hoping to make ends meet, or just like the Vitruvian Man by Leonardo, where Leonardo managed somehow literally to put a square into a circle by taking advantage of human proportions. But first things first, this is a project about finding new meanings to already collected randomized controlled data. And so the first step was to gather all the evidence to work with, all the evidence available on the topic that I was interested in. So that is to say, performing a systematic review. Systematic review to retrieve all the RCTs that tested a task-shared psychosocial intervention that is being delivered by a non-mental health professional worker. All the trials that have enrolled adults suffering from either depression, anxiety, or related comorbid disorders, somatic disorders. And who had received a task-shared intervention as compared to care as usual, and with the outcome being the reduction of symptomatology and the settings, low resource settings, poor resource settings, both in low and middle income countries or in poverty pockets of industrialized countries. We searched PubMed, Embase, PsycInfo, and the Cochrane Library, and we included 34 studies, 28 of which are published, and 6 studies have yet to be published. These 34 studies, 28 of which already published, tested 12 different psychosocial interventions. Some of them were tested multiple times. For example, you see the PM Plus was tested 11 times in the published reports. Vikram's LT activity program 3 times, and SH Plus and Friendship Bench developed by Dixon Shibanda 2 times, and so on. But, so the first step was, the first step of the qualitative part was to build a component taxonomy to be applied then for the second part of the project, which is measuring what component is the most effective, relying on the data published, or the quantitative data published on the trial reports for the aggregate level part, and then at the individual level, taking advantage of individual participant data. So the first step to build the taxonomy was to retrieve all the manuals, to read them, and to extract components to build the taxonomy, right? So the first setback was that I was able to retrieve 9 out of the 12 manuals, and for 3 of them, I was not able to get the manual. So as a first limitation, I have to anticipate that the taxonomy was built out of these 9 manuals that I had access to. And also, since some research is yet to be published, I worked on 24 RCTs instead of 32. These are the manual covers for the 9 intervention manuals that I read, and that helped me to build the taxonomy. And you see there's the PM Plus, SH Plus, Vikram's LT activity program, the Friendship Bench by Dixon Shibanda, 2 manuals on interpersonal therapy, and another manuals that is the addressing anxiety and depression, then the antidepressant skill workbook, and finally the group support psychotherapy developed by Petrelda and Akimulimpungu. And what I would like to do now is to walk you through the steps that led me to create the taxonomy, as I will present it to you. So in the beginning, there was chaos. Chaos being intended not as a situation of confusion or disarray, but intended in the Greek mythology sense of the term, namely a void state preceding the creation. So I left this slide intentionally blank so that you can feel the pneumatic vacuum I was starting. I had when I was starting to deal with the problem of building the taxonomy. I felt that I needed a compass and some cardinal points to hang my thinking on and get traction to get the work, or at least start it. So the first thing that I become aware of that I had to tell common factors from treatment-specific factors. Common factors being those factors that are assumed to be universal for the delivery of any effective treatment, regardless of which treatment-specific approach is used. Whereas treatment-specific factors are processes by which a particular intervention is theorized to produce a psychological benefit. taking a step further, I also have the idea to tell components from techniques. Components, a component being a process of steps and skills through which a person can implement changes in directions that he or she deems desirable. Whereas techniques, and this is according to my reasoning, of course, these are really uncharted territories, are the particular set of steps and skills that identify a specific process or components, right? So where to start to do this component extraction exercise? Of course, seems obvious to start from the text of the manuals. For example, this is the introduction of PM+. PM+ is a brief intervention that aims to help you manage emotional problems, such as feelings of hopelessness, fear, or sadness that are common for people living in difficult circumstances. It has 5 weekly sessions, 90 minutes for each session, and 4 strategies are taught. Managing stress, managing problems, get going, keep doing, strengthening social support. So it seems pretty obvious to me that these, the name of the chapters, were the components I was looking for. So relaxation, problem management, behavioral activation, strengthening social support. Same for this other example, the antidepressant pill workbook. It says that the emphasis in this book is on 3 steps: reactivating your life, changing negative thinking habits, and solving problems. Again, this sounded to me as behavioral activation, cognitive restructuring, and problem management. So we now have the first 5 components of our taxonomy, but how to categorize them? I felt I was needing to put these components into buckets to make them, to put them in good order. And the first and only thing that at the beginning, made sense to me was to organize them into these 3 buckets: a cognitive area, behavioral area, and an interpersonal area. Again, I'm walking you through the very steps that I processed in the last year and a half. In this way, at least 3 of the 5 components could have been rightly categorized, or it seems that they could be a good fit for these 2 of these 3 buckets. But what about problem management and strengthening social support? It seems to me that they were not really pertaining to any of these 3 categories. And same for the other components that I have identified, reading the other 7 manuals, right? For some of them, it was pretty obvious where these components should have been put. But for others, same problem as before. So the next step of my reasoning was to combine these buckets into a Venn diagram so that all the components could, be allocated in a fair way. But remember what I said at the beginning. This is about qualitative to become quantitative at a certain point. And here is apparent, it's obvious that some component belongs to more than one category. And that could not be. There could be no ambiguity, because the effectiveness of the components would have to be measured later. So now, bear with me with the next passage, but I felt that the correct way of grouping these components was not this, that was telling more about my way of reasoning, but this was a better way, more, more in line with what is written in the manuals. So in the manuals, these components after reading the manuals 1, 2, 3, 4, 5, 10 times, I become aware that this was a more natural way of putting components together. And you see that some of them are grouped and some others are not. In this way, I come up with the first assumption of the taxonomy that components had to be grouped into families, 6 families to be for the precision. And these families are psychoeducation, cognitive processes, stress and emotional management, behavioral activation, problem management, and interpersonal relationship and support. We will briefly go through each of them. So psychoeducation is the process of providing individuals with information and skills to understand and manage their mental health conditions. It includes teaching about symptoms, treatment options, coping strategies, and ways to foster resilience and recovery. Typically, at the beginning of each manual, you can see that the counselor is prompted to provide information about disorder, what is depression, what causes depression, what are the symptoms of depression, to provide reassurance to the patient that depression is a transitory condition, and so on. Then cognitive processes that include strategies aimed at modifying dysfunctional thought patterns and promoting adaptive behaviors to develop healthier perspectives. And both second and third wave strategies are considered in this family of components. And the most prominent component of this family is insight building, which is very much well explained by this infographic taken from the Healthy Activity Program, which is Bikram intervention, where the counselor and the patient work together to create links between thoughts, feelings, behavior, and emotions, discussing what happened, how did you feel, what did you do, and then what is the connection between these 3 questions. In another manual, this is the antidepressant skill workbook. It is explained that there are 5 major factors: situation, thoughts, emotions, action, and physiology. And each of these areas can play a role in the development of depression. And depression itself can have an impact on all of them. Again, basically each manual has an infographic to facilitate the creation of links between emotion, thoughts, feelings, and behaviors. And for example, this is the one of Dixon Chibanda in the friendship bench intervention. So the components of the cognitive processes that I have identified are insight building, cognitive restructuring, acceptance, and mindfulness, which are the left end of the spectrum that takes us to the third family of components, that is stress and emotional management, which contributes to the taxonomy with the components emotion regulation and relaxation. Stress emotional management involves techniques to reduce stress through relaxation and control emotional responses using emotion regulation. The fourth family of components is behavioral activation, of course, which can be broken down into identifying values and goals, activity scheduling, graded task assignment, and addressing avoidance behavior. Whereas problem management is made of listing problems, choose a problem, problem definition, brainstorm, decide and choose out 2 strategies, and make an action plan. Finally, the last family is interpersonal relationship and support, which involves strengthening social support, enhancing communication using interpersonal techniques, and or developing assertiveness skills to build supportive connection and improve relational dynamics. The components of these families are strengthening social support, income generating skills, interpersonal focus, assertiveness training. So let's stop here for a second and let's take stocks. Let's take stock. We said we have components intended as processes of steps and skills through which a person can implement changes in direction that are deemed desirable, which belong to family or families. And this introduces first level of discrimination. But we also said, if you remember the compass, that components uses techniques, and techniques are the particular steps and skills, the particular set of steps and skills that identify a process that is a component. And this introduces a third level in our taxonomy. So we have a three-structured, three-layers taxonomy with 6 families, 12 components, 44 techniques, where techniques are techniques, exercises, or tools that are, again, steps and skills that identify a particular process, namely a component. And this, of course, is with the, the icons that I've used before in the past slides. But I wanted to stress the fact that these components respond also to an harmonization criterion. So techniques are put together one next to the other in a way that there's a continuity between them, just like, a piano keyboard. And remember, this is as a taxonomy that was thought to be used to measure, that was thought to be used also for quantitative purposes. So since one can buy what his pocket can afford, one could define himself to be in the possibility of using 44 piano keys, or 12, or just 6, right? So there's flexibility. The more data you have, the more in depth you can go. The less data you have, the more rough the analysis will be. But also remember that when I switched gears from the Venn diagram to the other way of categorizing components into families, this is pretty much reflected here, because we have the high end of the spectrum being very cognitive. Then we have this transition phase from cognitive to emotional, where, for example, cognitive diffusion and grounding are techniques similar between them, but one is categorized as acceptance and the other as mindfulness, but I put them one next to the other. As for emotional awareness and emotional regulation, they are very similar, but emotional awareness is very much third wave, whereas emotion regulation is second wave CBT. And then we have relaxation, which is a bridging component for that lead us to the behavioral block of the taxonomy. And we finish with the interpersonal part of the spectrum. But okay, now we have the components. We've built the component taxonomy, but which is the the percentage of manual containing each component. We see that every manual, basically all the manuals, had made reference to psychoeducation and insight building, most of them to problem management and relaxation. But again, this is something qualitative becoming quantitative. And this is the presence of the components into the 9 manuals. We would be more interested in see how in measuring the presence of the components into the trials, because some trials tested more than one trials in some occasion tested the same manual. So in this infographic, you see that first of all, the components are no longer organized into families, but in the descending order of prevalence. And the blue bars are the presence of the components into the trials that tested the components, whereas the gray bars are the components, the presence of the components into the manuals. You see that, for example, behavioral activation is 33% when we consider the manuals, where the denominator is 9, but jump to 62% when we consider studies. Why? Basically because before cognitive behavioral activation was present in PM+, and PM+ was tested 11 times. Whereas interpersonal components were more prevalent when studying the manuals, because 2 out of 9 manuals are of interpersonal therapy, but there are only 2 trials that tested interpersonal therapy. So from 2 out of 9, they became 2 out of 24, and they dropped, their prevalence dropped, right? So since we're doing this for quantitative purposes, we will continue to deal with the presence of components into the trials, not into the trials. This is just the same thing pushed a little back, pushed on the left-hand side of the screen. And but as I was saying to you, we also measure techniques. So we can also have a details of the presence of each techniques into the manuals, right? For example, every thing that has to do with problem management is very much represented. Linking thoughts, feelings, and behaviors is always present in all the manuals, as psychoeducation is. Now, linking the qualitative and the quantitative part, right? We will be having some consideration on the strength of components and some statistical contingencies that needs to be considered. Let's start by saying that each technique was identified in the manuals, and for each technique, a chunk of text was extracted. But also, we decided to score the technique as 0 point, the technique is not present into the manual. 1 point, the technique is mentioned, but it is not critical to the structure of the manual. And 2 points, the technique is central to the structure of the manual. For example, the name of the chapter of the PM+ that I showed you before, that was 2 points straight, no discussion. But let's take, for example, assertive communication in PM+. The manual emphasizes the importance of clear and assertive communication in helping clients express their needs and boundaries without aggression. It highlights that assertive communication allows clients to convey their thoughts and feelings in a respectful and effective manner. So, in a certain way, assertive communication is present in the PM+ manual, but it is not as important as problem management or behavioral activation is. So we scored this with 1 point instead of 2. Why this is important? Because this is the taxonomy tree for PM+. This is not all the components and the techniques that I showed you before, but just the components and the technique that could be found into the PM+ manual. But this does not tell us anything about one component or technique being more or less intense in the manual. But with radar charts, we can overcome this issue because it's immediately apparent that, for example, cognitive restructuring and relaxation are there, but are not as, important as, for example, behavioral activation or strengthening social support. Always remembering that these components are arranged according to the family they belong. And I did this for all the manuals, right? So this radar chart in some way can also be used as a diagnostic tool. For example, for the sake of curiosity, just look. So that in the first line, there are the manuals that were developed during the first decade of the new millennium. In the second row, the manuals that were developed between 2010 and 2012. And then SH Plus that was developed in 2021. Please leave aside the two interpersonal manuals for the moment. What is apparent is that in the first line, the manuals that were developed during the first decade of the century, they seem all pretty much similar, and this is because they mostly applied cognitive behavioral principles of the second wave. Whereas, as the third wave starts to kick in the second decade, some little convexity can be identified here. You see, this is the Vikram's manual and Dixon Shibanda's friendship bench, but they are not very strong. But this to see to just out of curiosity to say that third wave CBT started to kick in the second decade, whereas in 2021, SH Plus was basically all third wave CBT, right? But please always remember that these manuals were tested into trials. And for example, PM Plus was tested in 11 trials, whereas the Friendship Bench in 2, and the Healthy Activity Program and the SH Plus in 3 trials, and all the other manuals in just 1 trial. So this will have consequences when we will talk about the quantitative analysis, right? Because it's for sure that the components that belongs to the PM Plus will influence the analysis much more than those belonging, for example, to the antidepressant skills work. Coming back to the intensity. So we have SH Plus was broken down in these 6 components. 2 of them were scored 1 point, and 4 of them were pivotal to the structure of the minds, right? And this is the Friendship Bench. Different components. Some components are the same, but scored with different intensity. Qualitative. Now let's switch gear. Let's change gear and switch to quantitative, where these manuals were tested into trials. In trials, in order to get an effect, intervention had to be compared with a comparison group. which in this case is care as usual, to get an effect, right? And please remember that my analysis is a network analysis. So these two trials will in a brief, I will show you how I put them into a network, right? Into a statistical network with a very important statistical assumption, which is called the additive model, that assume that the effect of combination therapy is the sum of the effect of its components. That the components have the same relative effect, and that there are no interaction between them. What does it mean? It means that mathematically wise, it is not correct to put in the same network two interventions that have the same components scored with different intensity, right? All the components must have the same intensity. That is to say, in order to get the full effect, the relative effect of each component must be broken down in equal, in an equal way. And it is not possible if the components are, the weight of the components is different, because some was scored with 1 point and another with 2 points. So the first big assumption that I made in statistical terms is that I had to remove components that were scored 1, that were not pivotal to the structure of the manual, in order to be okay with statistics, right? And make the individual component to contribute in the same way, with the same strength and intensity inside the network. But what consequence this has to the taxonomy? Well, you see that in this chart, the blue bars are those I showed you before. That is the presence of components into the manuals that were tested into the trials, scoring both 1 or 2 points, whereas the gray bar are the components that were scored with 2 points alone. So it's the gray bars, it's 2 points, whereas the blue bars, it's 1 and 2 points. And what we can see that for some components, nothing changes. For example, problem management was 88%, it remains at 88%. Same for behavioral activation. That, what is the meaning of that? It's the meaning that, it means that when behavioral activation or problem management are employed in a manual, these are pivot for that manual, right? Whereas, see for example, assertiveness training. Assertiveness training is basically everywhere. Every manual site that is important to be assertive, to have an assertive communication. But only 12% of the manuals make of assertivity a cornerstone, right? So this is the reason why it felt, fair to proceed to the statistical analysis, getting rid of all these components, all those components that were just mentioned in the manual, but likely didn't make the difference in the changing of symptomatology. And now, still talking about quantitative transition to quantitative. This is, the typical conversation that happens between a clinician and a statistician, because the clinician, who's the man with the red shirt, pulls toward the direction of techniques, which means granularity of information, whereas the statistician pulls in the opposite direction because he wants to have the data set as simple and clean as possible to make statistics more reliable. And this is the struggle I found myself into because for this project, I'm doing both, right? I'm a clinician, but I'm also a researcher. So I understand the language of both the clinician and the statistician, and I need to find a way to make everybody happy. That often it means make everybody angry, right? These are some statistics about the trials. There are just more than 10K participants involved, 12 manuals, 75%, 74% of the enrolled participants were females, mean age 37 years, study duration, mean study duration 2 months with 17 weeks of follow-up duration, and a mean number of six sessions per manual. Most of the trials were published very recently after 2020. 12 RCTs tested individual therapies, 12 group therapies, and 4 were guided self-help therapies. Most of the randomized of the trials randomized participants individually, and 33% of the times the randomization was a cluster randomization. This is a pretty basic pairwise meta-analysis showing nothing new. This is just a replication of a meta-analysis that Daisy Singla did in 2017. And it's fully consistent with an effect size of 0.53, which is a medium to large effect size. This means that what I was saying at the very introduction of my talk, that we know that task-shared psychosocial intervention are effective for the treatment of depression and anxiety. But from here, we took a step forward. And as I was saying to you, we build a network where each node is a manual. You see, ETHAU is enhanced treatment as usual, and then there is the friendship bench, the group support, psychotherapy, the guided acting field. These are all the names of the manuals, right? The healthy activity programs, IPT, PM+, psychosocial counseling, SH+, and the thickness of the line is proportional to the number of participants which contributed to the network. And the dimension of the node is proportional to the sample size, of course, of the trials that have enrolled such participants. With this, what is really, what would be really visible to a meta-analyst is this network is poor of cross connections. This because all the psychosocial interventions were tested against an inactive comparison. There are no trials that tested, for example, PM+ against SH+, or GSP against ASW. And in this, it would be, useful to have some trials testing 2 interventions head-to-head, and of course this is what is happening in India with the trial that Julia is leading with Bikram, which is about testing the efficacy of the healthy activity program against psychotherapy, right, Julia?
It's
psychotropic with
antidepressants. Yeah. Right. Unfortunately, I won't contribute to your network.
Yeah, but we can have a network where a node is pharmacotherapy.
Yeah.
Why not? And this is the ranking for the efficacy of each of the manuals. We can see that basically all the manuals, the point estimate for all the manuals is in the territory of being more efficacious than control as usual, which is the reference in this graph. But this is about components, right? As I told you. So we can do the same network, but with the interventions dismantled as a sequence of components, right? To be honest with you, these are not the components. This is not the second level, it's the first level. This is the therapies are broken down into a sequence of families of components, not components. Why? Because we have 12 components for 12 manuals, but we had to add the care as usual component. So we have 13 components for 12 manuals, and this translated in mathematical terms, in equations, does not work. There cannot be more components than the number of lines in the equation. Lines in the equation are the combination of components for each manuals, right? So I had to revert to the 6-node piano key, right? Not the 12 one. And what I found is that the most efficacious component is problem management. The most efficacious family of components is problem management, which is both a family and a component. Whereas, of course, as expected, the most, I wouldn't say detrimental, but the less effective is care as usual, basically doing nothing. This is very, this is not final, it's preliminary. I've done the analysis by myself. I will need to do this analysis again with the help of a statistician, so this is very, please take it as very preliminary. So there are many limits, of course, to what I have shown you. Of course, there are manuals of varying size and specificity level. The Dixon Shibanda's French bench intervention is 200 pages, whereas one IPT manual is 15, right? So, of course, it's easier to identify components and technique in the first rather than in the second. Only nine manuals were coded, and this could have led to some sort of selection bias. The taxonomy applies only to psychosocial treatments for common mental disorders, so there are no components about exposure or trauma focus. Nodal manuals were retrieved, 3 out of 12 are missing. Assumption had to be made to fit the model, and there are no cross connection at the network level, and this is, this made the network not that reliable, statistically wise. But still, there are some strengths. For example, as I said to you, the taxonomy was built thinking about quantitative purposes. So it can be used both for qualitative and quantitative purposes with 3 levels of depth, so that you can buy what your pockets can afford. It can be expanded to include other components, for example, trauma focused, and introduce the distinction between processes and techniques. This was for the aggregate data level, but this is about individual participant data, right? So I wrote this letter to all the trial authors, asking them to provide me with the individual participant data. And I was lucky enough to collect the 89% of the IPVs. So now I have almost 11,000 individual participant data to be analyzed. And this is how RCTs looks like in the R environment. And all these trials have been harmonized, meaning that they now speak the same language and can be, analyzed as if they were a unique mega trial, a unique very big trial made of 11,000 participants enrolled or observation. And this is how the dataset looks like. It's pretty standard. We have participants ID and the code for the intervention. 9 in this 9 here is related to the friendship bench intervention. Then demographics, gender, age, education, marital status, and occupation, and then the section about the outcomes. Of course, for the component analysis, 9, which is the friendship bench intervention, will need to be replaced by the sequence of components, which in this case is psychoeducation, plus insight building, plus problem management, plus involving a significant other. But also, there were a lot of missing data, and handling missing values in that analysis is essential to construct a good prediction model. So the easiest way to handle missing data is basically to drop them, right? But this can lead to loss of information and invalid conclusion in the data analysis. So we did some data imputation using the misranger R package, which uses machine learning algorithms, using the rule of thumb suggested by White in 2011, that is, we did multiple imputation at least equal to the percentage of incompleted cases. So if you have one data set with 100 observation, 10% of which are missing, you have to do 10 rounds of multiple imputation, and you will end up having a data set of 1,000 observation with no missing data. As a consequence, we did this for all the 34 trials, but the consequence is that I was starting with 11,000 observation, and I ended up with 258,855, all concentrated in this object, which is ready to be analyzed. This object called reshift of 37 megabytes that has all the information inside, just concentrated in just one object. And you may understand what it feels like to me, knowing that in the next year I will be dealing with this, with the data analysis of more than 250,000 observations, all concentrated in just an object. So this is to be continued, because I'm presenting the results of the first 2 years of my fellowship, but I have a return year, so the fellowship total duration is 3 years. I still have 1 year ahead of me when I'll be dealing with this stuff. So, coming to the conclusion, when I came here 2 years ago, I felt like someone dropped me at the base camp of Mount Everest, right? And I needed to find my way to the summit. And of course, getting to the summit it's difficult, and there are some camps of milestones scattered across the way. So camp 1 was reached when I built the taxonomy, that it can be used for qualitative, also for quantitative purposes. The second, camp 2 was to measure the efficacy of components at the aggregated level data. Camp 3 was collecting 11,000 IPDs, having them harmonized, having them inputted, and having them ready for analysis. And to do that, I got in contact with around 60 researchers from all across the world that sent their data to me, basically trusted me, that was not to be taken for granted. Camp 4, of course, will be to get the analysis done. but I wouldn't feel I will reach the summit this time because of all the setbacks and all the assumptions and all the compromises that I had to make, to get qualitative transitioning into quantitative, right? But at least it was fun, and hopefully it paved the way for someone coming after me. There were some times that I'm honest with you, there were some times where I took some decision totally, based on my instinct, on my gut, and that I was not really secure of what I was doing. But as a research scholar, much more entitled than me to speak about it, if we knew what it was we were doing, it wouldn't be called research, would it? Thank you.
Okay, thank you very much, Davide. Let's see if there's any questions in the room. Yes, Julia.
Yeah, great. Thanks very much, David. It was very nice and interesting discussion. I just have a question, whether you have, so obviously what happens in the manual sometimes doesn't actually translate to what happens in the sessions, right? So there's a way for us to, we're typically assessing, does it actually highlight the fidelity to the treatment, right? Is there something that you're gonna also look at?
No. Good question. I'll be honest with you. This is not possible.
Right.
So the other big assumption is that fidelity is 100%. Yeah. A lot of assumptions. That's another reason why I'm more confident in saying you that I won't make it to the summit, because this is a real clinical limitation that I'm not able to factor in the analysis.
But I mean, for instance, for HAP, I know we have ratings, right? Fidelity ratings. So you could have some sort of weighted thing where that's one of your variables, right?
Yes, this can happen. This would be, for 10, 20% of the times. Yeah. For all the other trials, this information is not there. Mm-hmm. But thank you.
I'm curious, when you were developing the taxonomy and even weighting the different components, did you have communication back with the developers of the manual when you were communicating? You said with over 60 other researchers. And I'm curious, were there ever instances where they said they would have weighted it differently? Or if they confirmed they agreed with how you organized everything?
This, of course, I will do. For now, I'm one step back from that, because now with Gloria, Anushka, and Federica, and another junior researcher in Verona, we're dealing with, we're cross-checking if, we're doing some sort of inter-rater reliability checks, namely to see if the technique that I've labeled in a certain way, Gloria, for example, will label the technique as the same ways as I did. We will do this, and we were talking about how to set up the software for qualitative analysis just right before the start of the meeting. Once we do this, I will be in touch with the manual developers, asking them to guide me with refining the taxonomy.
Also, your slides were beautiful, I have to say too.
Yes, you said.
So we use Problem Management Plus in Mexico, Peru, Malawi, Lesotho, Rwanda, Sierra Leone, Liberia. Everybody loves it, and it works. And we use psychological first aid, and we use CETA, and we're agnostic. So, like one day, how will we take this when it's been taken to the next level and use it? Is it a template for like systems to think about task sharing across a continuum? of specialized workers that they can tailor and pick?
At the end of the day, actually, at the end of the next year, because my fellowship is gonna come to an end next year, I will analyze data with individual participant data, and it will be possible to know, for example, which components works best for example, people with a certain level of education, or a certain marital status, of a certain occupation status, of being younger or not that younger according to the age. So it will be, the prediction model can, will be in the possibility of saying, for example, behavioral activation is more efficacious for young people with a college degree, right? Whereas psychoeducation is more helpful for everyone. Whereas, problem management works better for women in the late age, right? This is the what we will be able to do and what will be automated into software. We will be able to, you will be able to insert the characteristics of the participant, or someone with depression and anxiety, and know, at least have an idea of what components work best for that man or woman.
So it could be embedded within a system of care at some
Absolutely.
point using technology.
Absolutely.
Yeah, and I think if I could add to that too, I think what's really nice about that is, so essentially we did the same for Quip, the whole platform. We did a whole all coding of manuals, the taxonomy. David and I both can complain about how difficult and stressful it is. That led to what the tools are now on the platform.
Right.
After many, many people reviewed it, tested it in a way that it's formatted so you can have it specific to a PM Plus manual intervention. There's a PM Plus tool, fantastic. But there's also what we set it up specifically was in terms of having competencies that kind of separate into these buckets. Underneath cognitive, you have XYZ. So you can imagine that at that next stage level that you were just describing, Davide, it would be really great to also, I mean, pretty much the taxonomy you have more or less already matches to what the competency tools are. And so then now you have not only how do I decide what this person needs for support, but how do I make sure that the people that are delivering the support have the skills that they need to do it? And I think that that is actually pretty useful and applicable for systems of Christian.
Yeah, I'm really interesting methods. I'm just I'm curious. The manuals were used and tested in so many different countries, but I'm assuming the manuals that you coded or looked at were all in English. And I'm just curious how about cultural or contextual adaptations to the manuals? And I'll use HAP actually as an example. The HAP being evaluated in Optimized D that Julia is working on looks nothing like the HAP that you probably looked at and coded. So I'm just curious, because it was completely redone and redesigned and adapted to a totally different part of India, a different language. So I'm just curious how you factored in the different adaptations, because it might really change some of the components in the intervention.
Yeah, that also was not possible to do. I had the English manual and I coded the English manual.
Mm-hmm.
So there's really, so the more you want to get into detail, the more you get frustrated. Because there are always elements that don't allow you to do what you want to truly would like to do, right? And this is what the leitmotif of my presentation is, the obsession to working at the interface between qualitative and quantitative, right?
You shouldn't let that be a frustration. You have to do something after the 3 years is over. It just means more work.
You also need the data, like that's the thing, like they don't report it. Like some people might, and if they're happy to talk to you, great, but a lot of the time it's really hard to even find that information. Like, can we have that manual that was contextually adapted? Oh, I don't know, maybe, find parts of here, or do you have the process written down? I think that's also definitely what you already mentioned earlier, right? In terms of fidelity, in terms of how are people trained, does it even matter how much content is in the manual? If you have all problem management plus, how, besides fidelity, how much of it, assertiveness training, for example, that could be a huge piece that they do in problem management plus, depending on who they're delivering it to. But we also don't know, are they trained, just because there's a couple of sentences, how much are they trained on it? So I think it's also I'm very much supportive of how frustrated you are, and I feel for you, and I also see a future as well.
It's not about frustration, it's about reality check.
Reality check, yeah. Honestly.
Any other questions? Oh, are there people online? I don't know.
There are, but they haven't had any questions yet. Professor Barbuli's actually.
Okay. Should we allow him to speak? Is
Oh, if
he?
you would like to.
I don't know if he's having any.
Yeah, I think they can unmute and talk, I think.
I asked them to raise their hands if they had any questions to ask, but he didn't say anything, but I just asked him specifically. If he had anything.
Another cool thing, Davide, to look at this in the future, when like large language models are like super powerful, is to look at actually transcripts of sessions or audios of sessions. Because I think LLMs are still kind of like, but I think this will be something very, very powerful to do in the future.
Yeah, sometimes I feel that the work I'm doing is I'm doing it to make people in the position of saying the things that you're doing, saying for future references, for future studies. That's what I was talking about when I said I'm feeling like I'm paving the way, because these questions only arise when someone tries to resolve them and doesn't have the power, the information, the data to get this specificity. And also this means that also data should be collected and reported in a more granular way, right? So it's the never-ending discussion about the reliability of meta-analytic data and the goodness of reporting of RCTs, right? If RCTs are not well reported, automatically meta-analytic estimates are put at risk to be biased, right?
Professor Barbui said, well done, and he's looking forward to seeing you in Verona.
Well,
I'll see you on Monday,
great. Well, thank you very much, Davide. It's incredibly important work. You're trying to help us understand how these interventions actually work. So I think it's it's incredibly valuable. And I agree, you're paving the way. It's helping us.
Thank you.
So thank you. Thank you, everyone, for joining, and thank you for our lab for also joining. I know it's been a really excellent afternoon. And thank you again, Jen and Scott.
Thank you.
Madeline.
Thank you.
Thank you so much. These chairs are yours.
I just realized they're meeting on Wednesday night. You're here Wednesday, otherwise we could. You were saying Wednesday would work, but I was practicing.
Everyone, we usually take a break at the end of every lab day.